Good morning. Thank you very much for the kind presentation, and I'm really glad to be here with you and share this with you today. This is going to be an interactive session discussing a diabetic patient who happens to have renal problems, and we're going to touch on the multifactorial management concerning hypertension, lipids, and hyperglycemia.
It's my pleasure to be with you here in this elegant meeting, and we thank Professor Ines Chatout for inviting us to contribute with you in this workshop. And my pleasure to share the case with Professor Maya Hasaballah, Vice President of the Egyptian Society of Nephrology and the President of the National Kidney Foundation. And our case today is Mr. Hassan. He is 53 years old. He is a non-smoker. He is divorced and recently fired from work, presented to the outpatient clinic for employment checkup. He is a stone former and gives history of repeated urinary tract infections. His body mass index is 25 kilogram per meter square, blood pressure 135/80. Otherwise, physical examination was unremarkable. His total cholesterol is 220 milligrams per deciliter, LDL 105 milligrams per deciliter, HDL 50 milligrams per deciliter. His creatinine is 1.3 milligram per deciliter. And as Professor Omar Saadani has just mentioned, we have to know his EGFR. His EGFR is 62 milliliters per minute. 62 milliliters per minute. His sodium is 138 milligram per deciliter, potassium 3.8, hemoglobin 14 grams, and random blood sugar was 150 milligrams per deciliter. Ultrasound was normal, and the ECG showed sinus rhythm with no signs of left ventricular hypertrophy. And now you have the first question. How many risk factors does this patient have for the future development of coronary heart disease? Well, let me revise again. He is 53. He is a male. His blood pressure is 135/80. His random blood sugar 150. His cholesterol is 220 and LDL 105, and he is a non-smoker. And his body mass index is 25. So he is a male and he's 53. What is the third risk factor? Let us continue. I will show you now that we will revise it again. Over 90% of coronary heart disease events occur in individuals with at least one risk factor. You don't need many risk factors. 90% of the events occur in individuals with at least one risk factor. And here are the traditional risk factors. Older age, he is 53. Male sex. Hypertension, we need to know the values. Higher low-density lipoprotein, lower low-density lipoprotein, diabetes, smoking, physical inactivity, menopause, and family history. But what are the values now? About blood pressure, systolic blood pressure is a risk if it is over 140 millimeter mercury. Diastolic is a risk if it is over 90 millimeters mercury. LDL is a risk if it is over 159 milligram per deciliter, and HDL less than 40 milligrams per deciliter. For diabetes, fasting blood glucose should be over 125, postprandial over 200. Over 199, I mean. So according to those values, he is a male and he's 53, but his blood pressure is 135/80, so this is not considered a risk. And the LDL is 105, so this is not considered yet a risk. The HDL is 50, and his blood glucose is random. This is the level which is given in this presentation. But there is new information now. 8% of events occurred in individuals who had only borderline levels of multiple risk factors. So we have established risk factors and we have borderline levels of risk factors. ايه حكاية البوردرلاين دي؟ وطلعت ليه؟ طلعت عشان في new definitions. Now انت عندك optimal blood pressure 120/80. طب if it is not optimal, if it is 125, isn't that a risk? It is a borderline risk. So the blood pressure is borderline when it is from the systolic when it is from 120 to 139, and the diastolic from 80 to 89. So our case is a borderline hypertension. What about LDL? It is borderline from 100 to 159. So he is 105, so he's a borderline. HDL from 40 to 59, he is 50, so he's a borderline. What about the blood glucose? From fasting blood glucose from 110 to 125 is a borderline, and postprandial from 140 to 199 is a borderline. Previous smokers are borderline. So the question is not that easy. The question says, what are the traditional established risk factors? He is a male and he is 53. If I said, what are the risk factors? So those are all traditional and borderline. So the new information is borderline risk factors are important because 8% of coronary heart disease can occur because of those borderline risk factors. And this is another a bit difficult question. What is the strongest predictor of coronary heart disease in our patient? Well, his blood pressure is 135 over 80, and this is borderline. But what is more important, the systolic or the diastolic, or both, or the pulse pressure? The answer is, which is difficult, it depends upon age. Less than 50, the most important is the diastolic blood pressure. From 50 to 59, the three parameters are important. Over 60, it is the pulse pressure. His doctor prescribed the atorvastatin 20 milligrams per day. And when the patient went home and read his lab results of LDL 105, he was reluctant to take the medication. But on follow-up visit, his doctor insisted, لازم تاخد. هو طبعا قرر لأنها مش risk factor. Do you agree with his doctor? لازم ياخد? Yes or no? If you agree, raise your hand. طيب كويس. Why do you agree with his doctor to add atorvastatin? This is one. He's not diabetic yet. الراندم بتاعه هو ال 150. ما حطش لا فاستنج ولا بوستران، ما اقدرش احكم. بس نمبر 1 هي از بوردر لاين. بس الاهم بقى هتقوله لنا الدكتوره منى.
Okay, according to the KDIGO guidelines, the incidence of atherosclerotic cardiovascular disease is very high in patients with CKD, to the extent that those patients should be considered in the highest risk category, equivalent to that of patients with known coronary heart disease. And according to the guidelines 2017, the patients that are at extreme highs, if you look at the LDL cholesterol, the new recommendation is to bring it less than 55. But again, this is different in our case because dyslipidemia is common in patients with CKD, but LDL cholesterol does not reliably discriminate between those at low or high risk of cardiovascular events. And the reason for that is, if you look here, this is the this shows you the relation between LDL cholesterol, and the hazard risk for myocardial infarction at different eGFRs. So if you look at the GFR of 90 mL per minute, you will find that the relation is steep, but as the GFR goes down, relation becomes weaker and weaker. So. And the reason is that we don't only have traditional risk factors, maybe these are not taking the upper hand, we have other non-traditional risk factors including homocysteine, albuminuria, anemia, abnormal calcium phosphorus metabolism, volume overload, electrolyte imbalance, oxidative stress, inflammation, malnutrition, and so on and so forth. So our patient, which stage is he as a CKD patient with a GFR of 62? This is stage 2 CKD. Okay, so what are the guidelines in this case? The guidelines say that in adults aged more than 50, which is also our case, with a GFR less than 60, not treated with chronic dialysis or transplantation, we recommend treatment with statin or statin ezetimibe combination, and this takes 1A recommendation. And in adults more than 50, again, with this CKD and GFR 60 milliliters or more, again, we recommend to treat with statin, and this is 1B. So if the patient is over the age about 50, irrespective if he is below 60 or more than 60, the recommendation is to give the higher recommendation when it is less than 60. So then, if you look here, this is, you can see the risk of myocardial infarction. Oh, yes. This is the incident myocardial infarction and cardiovascular coronary death. You will find that those patients with CKD have greatest risk, even more than those with diabetes and no CKD. And of course, this increases when you add more risk factors like CKD with diabetes or CKD with myocardial infarction. But this is very much age-related, because what I'm talking about now is those more than 50. If you look at the age group less than 50, you will find that if you have CKD, there is no increased risk. Risk increases only when there is another risk factors associated. So the recommendation in this age group, in adults aged 18 to 49 years with CKD but not treated with chronic dialysis or kidney transplantation, we suggest statin treatment in people with one or more of the following: non-coronary disease, diabetes mellitus, prior ischemic stroke, or estimated 10-year incidence of coronary death, or non-fatal myocardial infarction more than 10%. So if the patient is more than 50, you treat, and if the patient is less than 50, you only treat when there is another risk factor.
He was very stressed trying to cope with his new life. He noticed in the next few months increased frequency to urinate. Now his fasting blood glucose is 195 milligrams per deciliter. His postprandial blood glucose is 250 milligrams per deciliter. And HbA1c 7.8%. Blood pressure 130/80. Creatinine 1.3 milligram per deciliter. The GFR is still 62 milliliters per minute. And the albumin creatinine ratio 20 milligram per gram. He was told that he had type 2 diabetes mellitus and prescribed metformin 500 milligrams 3 times daily, and lifestyle modification. So number one, he had to modify his lifestyle, and he started metformin 500 milligrams 3 times daily. 3 months later, his HbA1c was 7%. His doctor added glimepiride, 2 milligrams per day. Do you agree in the decision of the doctor to add glimepiride? His HbA1c is 7 now. He took metformin, it went from 7.8 to 7. Then he added glimepiride. 25. Normal, he's not obese. So now, Dr. Ahmed.
Okay. Now our patient GFR is 62, and generally speaking, those above 60 can be treated along the common rules that diabetic patients is treated with. And of course, you know that, you know better than me, these rules that you can add on to metformin any of those drugs. So, well, if this drug is added, it can be added. I mean, it's nothing against adding this type of drug. But the point is, should we reduce the hemoglobin A1c less than 7? And this recommendation here says that you can go down with A1c less than 6.5% for those patients who do not have comorbidities and at low risk of hypoglycemia. And the reason for that is, of course, you're all aware of these studies when you do strict hyperglycemia control, that all these studies agree that there is a reduction in microvascular complications, and what's more is that this reduction seems to be durable, because according to the UKPDS, there is a reduction in microalbuminuria if you follow for the 3 and 6 years, but if you follow long enough, even after the end of treatment, it seems that this continues and is durable, and it's like there is a metabolic memory. So the earlier you do strict control when you can, because when the patient starts to develop comorbidities and goes through diabetic complications, you will not be able to do strict control. So the message here is that you have to do strict control early on to prevent the complications, diabetic nephropathy and other microvascular complications.
The patient was not compliant with the diet, and he mentioned that he sometimes forgets to take medications. 2 years later, بقى عنده 55 سنة, his HbA1c is 8, his serum creatinine now is 1.6 milligram per deciliter, and the GFR dropped to 48 milliliter per minute. The AC ratio as well increased to 150 milligrams per gram. And now he is in what? In which stage? His GFR is 48, so he is in 3B. And what changes would you do for control of blood sugar now? He is on metformin, he is on glimepiride, and he forgets to take the treatment, and he is uncontrolled. Change the dose of metformin? Yes or no? His GFR is 48. Metformin was reduced, glimepiride continued, and DPP-4 was added. Inhibitors were added.
Okay, yes, we below 45 we reduce metformin to 500 milligrams, and it's better to be stopped below 30 milliliters per minute. Although there are opinions now coming that you can continue with it because it has beneficial effect on the cardiovascular system and also on the kidney. So we come to that, not our subject today, but for DPP-4, you know that all are renally excreted except linagliptin. This is the only one that can be taken without a dose modification with a reduction in GFR, whereas all the rest of the drugs will have to be reduced. Sitagliptin you have to be reduced to 50 and then 25, vildagliptin from 100 to 50, and you go on with 50 till the end, and linagliptin you said no adjustment, and so on. So.
His doctor prescribed valsartan and asked for follow-up lipid profile. Do you agree that his doctor added valsartan here?
Blood pressure.
He's diabetic. His blood pressure 130 over 85. Well, 135 over 80, sorry. And his proteinuria now is 150 milligram per gram. Either an ACE inhibitor or an ARBs is recommended for the treatment of the non-pregnant patients with diabetes and modestly elevated urinary albumin excretion from 30 to 199 milligrams per day. فالعيان بتاعنا 150 milligram per day. And it is strongly recommended for those with urinary albumin excretion more than 300 milligram per day, and the GFR is less than 60. So it is strongly recommended to start. It is recommended to start his ARB here. But it is not advised, it is not recommended for the primary prevention of diabetic kidney disease in patients with diabetes who have normal blood pressure. فكان صح قوي انكم تسالوا البلاد بريشر كام البلاد بريشر كام. لو البلاد بريشر نورمال it is not recommended. ولو النورمال urinary albumin creatinine ratio less than 30 milligram per gram. So it is not used for primary prevention. So again, it is not recommended for the primary prevention of diabetic kidney disease in patients with diabetes who have normal blood pressure, normal urinary albumin creatinine ratio, and the normal estimated GFR. And what about screening for lipids? Do you agree that he screens for lipids? His GFR now is 48.
You agree? Okay, again, according to the guidelines, in adults with CKD, including those treated with chronic dialysis or kidney transplantation, follow-up measurement of lipid levels is not required in the majority of patients. So we don't screen our patients because they are to be given the drugs according to the GFR, not according to the level of cholesterol. And CKDs, grade 1 and 2, it is the usual dose that can be given, whereas starting from grade 5 downwards, onwards, you have to reduce the dose. So these are the maximum doses that are allowed for atorvastatin 20 milligrams, for fluvastatin 80 milligrams, for rosuvastatin 10 milligrams, rosuvastatin 10 milligrams. So you will have to be restricted by the GFR, not by the level of lipids.
His serum creatinine was gradually rising over the next 3 years to reach 2.5 milligrams per deciliter. The GFR now is 27 milliliter per minute. His fasting blood sugar 180 milligrams per deciliter. The HbA1c is 7.9 despite his medications. So now in which stage of chronic kidney disease? He is in stage 4 because his GFR is 27. It was decided to stop metformin and sulfonylurea and to continue in DPP-4 inhibitor and basal insulin and repaglinide.
Okay, considering insulin, actually basal insulin is the safest if you speak about insulin, because you know that 1/3 of exogenous insulin degradation is carried by the kidney. So when you have CKD, there is a greater risk of hypoglycemia, and you will have to reduce the dose of any insulin given according to the GFR. So if it's 10 to 15 mils per minute, you have to do a 25% reduction, and if it's less than 10, you have to do a 50% reduction. And according to the Canadian Diabetes Association Update 2016, these are the drugs that can be used with advancing kidney disease. And well, you can see here that metformin is to be stopped at 30, and saxagliptin is not recommended to be given. And sitagliptin, you have to reduce the dose. Of course, the yellow line is you have to reduce the dose. And exenatide, liraglutide, not recommended. And ripaglanide is safe to be given. And of course, the SGLT2 inhibitors, they have to be stopped at 45 mils per minute.
Mr. Hassan lost follow-up for the next 3 years. Then he presented with serum creatinine 9 milligram per deciliter, his GFR is 6 milliliters per minute, HbA1c 6.2%, LDL 95, HDL 45. So everything is good apart from his kidneys. And now the doctor decided to initiate hemodialysis and asked him to continue taking 20 milligram per day of atorvastatin. Do you agree with this? Should he continue atorvastatin? And his creatinine is 9 and GFR so low? Who agrees to continue atorva?
Okay, so, well, it's also according to the guidelines. In adults with dialysis-dependent CKD, we suggest that statins or statin-ezetimibe combination should not be initiated if it is not already given. But in patients already receiving statins or statin-ezetimibe combination at the time of dialysis initiation, we suggest these agents should be continued. يعني لو البيشنت بياخد already, we continue, and if the patient is not receiving, it's not recommended to start during dialysis. And the reason for that is the SHARP study, which was carried on a very big number of patients, more than 9,000 participants, and more than 3,000 were on regular dialysis treatment, and more than 6,000 have a GFR 27 mils per minute, and 23% were diabetics. And those patients did not significantly reduce the risk of the primary outcome in the subgroup treated with dialysis at baseline. So it is not indicated to start it in dialysis, but you continue if it's already receiving.
Before starting hemodialysis, his virology screening revealed positive HCV antibodies. Now he has hepatitis C. He mentioned to his treating physician that he would prefer to proceed for renal transplantation. And now the question is, what do you prefer? Should he start treatment before transplantation or later after transplantation?
احنا حبينا نزود هات الاتش دي برضه عشان نبقى aware، لان ده حاجه وارده في diabetic patients. طبعا transplantation is better than dialysis for those patients. لكن HCV is associated after transplantation, where there's a debate about the risk of acute cell rejection, but definitely there is increase in acute vascular rejection, thrombotic microangiopathy, and acute transplant glomerulopathy. So it's better to be treated before transplantation, and also there is a possibility of activating the virus getting activated early after transplantation. But of course, in the presence of this era of directly acting antivirals, you can treat also after transplantation. But the better is to treat before if you can do that. So which treatment would you start? PEG interferon?
طب نبتدي ايه بقى؟ Pegylated interferon once a week plus ribavirin ولا regular short acting interferon plus ribavirin ولا sofosbuvir plus ribavirin or others?
ايه رايكم؟ Others. Yes, of course, others. دلوقتي the recommendation for dialysis patients is to start non-sofosbuvir based therapy. So we don't use sofosbuvir, and better to use either Kerivo, which is a combination of ritonavir, boosted paritaprevir, or mitasvir with daily ribavirin, or we can use a combination of grazoprevir elbasvir. دي مش موجودة في مصر اللي هي اسمها زيباتيه بس يعني احنا منتظرينها. ف any of those drugs have no sofosbuvir and they are very well used and produce very 100% cure rate. And thank you very much.
يعني انا اول مره اشوف you are يعني very courageous. Can I ask a question؟ لو انا كنت from the very start عملت زي ما احنا بنعمل، شلت الميتفورمين وشلت الجليميبرايد وحطيت بيزل انسولين ونوفونورم ريباجليمات من البدايه، هل دي كان هيبقى ليها امباكت احسن على الديتيريوريشن بتاع الجلوميرال فلتريشن ريت ولا لا؟ اول سؤال. لان يعني احنا بالنسبه لكم طبعا الاعداد دي جميله، بنشوف وجهه نظر اكتشف ان انا طيب وخيبان. يعني انا من 1.3 انا بشيل الميتفورمين ده خالص ما حطوش ابدا. ايه هل انا لو كنت شلته وحطيت بيزل انسولين وحطيت واحده او اتنين نوفونورم ونص حتى ولا واحد، كانت تبقى باتر بروجنوزز والجي اف ار ما كانش ينزل 6 في الفتره دي ولا لا؟ ده سؤالي الاولاني. يعني احنا كلنا بتوع البطنه هنشيل على طول
هو بالنسبه للبريفنشن اوف دايابيتيك نفروباثي في حاجتين. اول حاجه ان احنا نعمل ستريكت كنترول irrespective احنا بنستعمل ايه. So the point is bring the patient to strict control. لكن في نقطه مهمه تانية قوي. Yes, I'm coming to that. نقطه مهمه ان انا لما استخدم لما تشوز من الانتي دايابيتيك ايجنتس انا احب اختار حاجه يكون ليها كمان بالاضافه انها هتكنترول الدايابيتس يكون ليها رينو بروتكتيف ايفكت وليها بلايوتروبيك ايفكت. يعني مثلا الاس جي ال 2 حلوين جدا دلوقتي بالنسبه للبيشنت اللي لسه ما دخلش قوي. لا يعني لغايه 45 ميلز بير مينيت. لو هستخدمه ايرلي ليه بلايوتروبيك ايفكتس كتيره جدا، ان هو بيقلل الانتراجلوميرال بريشر وبيحسن الويت والهايبرتنشن وكل ده بيبقى ليه ايفكت على الكدني. فانا الدي بي 4 انهبيتورز ليهم بلايوتروبيك ايفكتس احب ان انا استخدمهم. الميتفورمين بقى حضرتك لقوا ان هو حلو قوي في الكارديوفاسكولار بروتكشن which is very good، زائد ان هو ليه رينال بروتكتيف ايفكت ان هو بيستيموليت ايجافاني اللي هي في الدايابيتس والاكسيديتيف ستريس وكده بيبقى فيه البروسيس اوف ايجافاني اللي هو بيبقى فيها انتراسيلولر ديستراكشن للتوكسيك ماكرو مولكيولز. فدي من الحاجات الميتفورمين من الحاجات اللي بيستيموليت البروسيس دي. so this is good for the kidney. فاحنا لا هو الراجل ما بيجيش وكان بيقعد ب3 سنين ويرجع وما كانش بيلتزم بالعلاج. انما هو لو ملتزم احنا ما بنشيلش الميتفورمين الا اقل من 30 ومن 45 بنخليه 500 مللي جرامز. وزي ما بقول لحضرتك ان في ناس حابينه قوي ان هم بيكملوا بيه بال 500 مللي جرامز لغايه الداياليسيس. يعني it's not advisable at the time being لكن definitely ان هو حلو ليه other very good effects على cardiovascular protection وعلى الrenal protection.
في بس كومنت عشان الدكتور عمر اللي بيتكلم على الميتفورمين وبيخاف منه بعد ال 1.3 كرياتين. الحقيقه الميتفورمين مظلوم في الحته دي لان الميتفورمين فاليو وعلى زي ما سيادتك بتقولي على الكارديوفاسكولار سيستم وعلى الاذر فاكتورز، ولكن هم كانوا بيخافوا زمان عشان لاكتيك اسيدوزيس
هي مشكلة
فقالوا كده انما هو not injurious to the kidney. Yeah. So we can raise the dose of metformin to the half the dose medical.
الناس بيقولوا ما درتش مش الميتفورمين نفروبروتكتيف. احنا اتخانقنا على سبيكر يعني انا رديت قلت له لو دي مامتك ولا باباك ولا اخوك والكرياتينين واطي هتدي ميتفورمين؟ طب ايه الافيدنس بيست؟ ما عرفش يرد. ما هو الراجل طلع سكه اللي بيقدم.
انا بس عايزه اشجع ان احنا نستخدم الجي اف ار اكتر ودي فيري سيمبل وعلى الموبايل وبندوس عليه ونحط
بس في مشكله 6-7 طرق
لا
في طريقتين فيري سيمبل بيطلعوا رقم، وفي
CKD
طريقتين
epi.
تانيين
CKD epi is the best.
يعني لو طلع الطريقه العاديه بتاعتك مثلا 60، في طريقه ثانيه تطلعه 65 66 باذر بارامترز.
CKD epi is the one which is يعني اللي عليها consensus ان احنا نستخدم. This is the one which is
أي
most.
واحدة؟
CKD epi.
Okay, thank you.